what are the top 3 most important manageable lifestyle changes that an individual can take today to improve their cardiovascular health significantly?
By prescribing pills is helpful, but is not solving the problem. Instead, it would be much better to repair the problem. And that's where we close the loop, basically going back to stem cells. Because stem cell therapy, not yet, but in the near future, is part of regeneration and repair.
I'm 43. I want optimal health. I want to live as long as possible, high quality as possible. People like that have children, and do you think a V02 Max test is something maybe I should do once every 6 months, once every year? You're really at the forefront of, I hope I'm accurately describing where you're at in healthcare, but I would say it's medicine 3.0, just because it seems like it's so longevity focused, health, wellness, where we're going, where the trends are going. Would that be accurate, or is that completely wrong? I mean, where would you put yourself in this field of healthcare in 2023?
You just want to put me at a 3.0? I think I'm more than that.
Yeah. I like you, man.
It's all good. It's all good. Yeah.
Just before we even get started here, so are you just spending a lot of your days still with patients, or are you just in research labs, working on stem cell research, regenerative medicine, and at UCLA, correct? In Los Angeles?
Let me explain. So to your first question, I spend the whole day with patients. So I'm a clinician, I'm a cardiologist, and an interventional cardiologist and a transplant cardiologist. So I spend a lot of time with very sick patients who need a heart transplant because of heart failure. So besides this, however, I have spent years in a basic research lab and have done experimental studies and cell cultures on experimental animal studies and so on. And approximately 20 years ago, I was lucky enough to be one of the first with my colleagues to do what we call now stem cell therapy. And I can tell you briefly what we did. We did one of the very first studies was we used an animal experiment where we had pregnant rats. We took the embryonic hearts out of the embryos of the pregnant rats, isolated the embryonic cardiomyocytes, the heart muscle cells and the stem cells, and then transplanted those cells into recipient animals in which we created heart attacks 4 weeks earlier. And we published that in, I think, 1998 or so. And what we could show was 2 things at that point. Number one was that those cells did survive after transplanting them into host tissue, recipient tissues. And the way we could prove that was because we only used male cells or cells from males, and then by detecting the Y chromosome, the male chromosome in the recipients, using what is called a FISH method, a staining method, we could say, well, those cardiomyocytes and also the stem cells must have come from the transplant. So after 4 to 6 months, those cells were still there. So they did survive in the host tissue without immunosuppression or other means. So that was the number one big finding. The second big finding was then that compared to control animals, which were just treated with placebo, the heart function had significantly improved. Keep in mind, these were animals with experimentally induced heart attacks. So they had the low strength of the heart, the low heart function, low scar tissue. So by transplanting those stem cells and embryonic cells, we could basically show that those cells contribute to an improvement of the function, the reduced function after heart attacks. So that experimental study then was one of the first ever published using stem cells, and created an enormous hype then in general in the world people were saying, well, if that works in an experimental animal study, of course it should work in humans too. And that created then that hype on doing clinical studies in patients with heart attacks, in patients with heart failure, in patients with Parkinson's disease and other neurodegenerative diseases and so on. So we have been done that since that time, basically from the animal lab, we went to clinical studies, and I'm still doing that, or doing that in part. Not in the lab anymore, not in the experimental setting, but in clinical settings. And so far, every single study which ever has been published using stem cells for whatever conditions has shown benefits. And that's where we are today. On the other hand, and I need to mention that, of course, stem cell therapy is not FDA approved in the United States. So it's not something which is widely recommended and available. It is still in an experimental setting, so meaning we still need more clinical studies to prove that it's beneficial and not harmful.
How would you say sleep affects your cardiovascular health and the aging process?
Well, I mean, yeah, you're talking about the anti-aging or reverse aging. So the stem cells, and as you know, I mentioned that in the two books I wrote, one on stem cell therapy a year ago and one which just came out this month on immortality or anti-aging. It is not just one injection, of course. We have the means now to understand processes of aging. Why do cells age? What are the mechanisms for senescence? That's the scientific terminology for aging. And there are cells in our bodies who are senescent cells. They basically make our cells, our skin, our heart, our brain age. And since we understand those processes, at least in part nowadays, we have means to overcome that, not to prevent aging, but to probably reduce the speed of it, and to inhibit the progression of it to some degree at least. And in order to do that, again, stem cell therapy is just one little part of it. Regenerative medicine is one part of it. But the whole lifestyle modification is another major part. And that includes things like, we can talk about this in detail more, of course, like dietary habits, like exercise, physical activity, sleep pattern. You mentioned that, Nima. So it's an enormous important aspect. So if our bodies do not get enough rest, so if we have a chronic sleep deprivation, for example, this induces chronic inflammation in our body. And we all know now inflammation is a horrible thing, because it's not just there and goes away with some swallowing some ibuprofen. No, inflammatory processes play a major role in the aging of our blood vessels. So sleep deprivation is one of the major issues which can lead to chronic inflammation.
What would you say if someone, if a person like me, a layman, just, hey, Dr. Schwarz, what are the top 3 most important manageable lifestyle changes that an individual can take today to improve their cardiovascular health significantly? Top 3.
Well, I think number 1 is, and we learn this more and more, is diet. And number 2 is physical activity. And it's not the physical activity, meaning go running to a gym and spending there 2 hours a day. If you look at the blue zones, I'm sure you're aware what that is, those 5 areas in the world where people live 100, 110 years old. None of those people ever have seen a gym from the inside, but they're always physically active, And number 3, in my opinion, is a healthy mind and faith and soul. And that's, of course, a big thing to say, but it includes, for example, the fact that we need a purpose. You know, in the blue zones, for example, those people, they're heavily, despite their high ages, they're heavily engaged and involved in their communities. They're active, they participate in community activities, they have tasks, they have something to do and look forward to. And the major drive for that is, of course, a positive and healthy mind, whether it comes just from being a positive person or whether it has to do with spirituality or religious faith or belief in higher powers. I'm the biggest believer. I'm a theologian, as you know, so I'm the biggest believer that faith and spirituality plays a major role on how not only we deal with diseases, but also with regard to outcome of certain illnesses. And we have studied that in different settings in the past.
What you were going, I cut you off, but you said number one, eating. You said something along the lines of you are what you eat, and then I cut you off. What were you going to say?
Well, I mean, we know now more and more. I mean, every day something is in the news. Yesterday there was an article in the Daily Mail, for example, from the UK, that there's more and more food ingredients, especially conservatives, which are linked to cancer now. I mean, our current diets are just horrible. I think we need to go back to eat, number one, less calories, because that prolongs life. Number two, we need to reduce definitely the intake of meat. And I'm not a vegetarian or vegan, but I think the meat intake, in particular in the Western world, in particular red meat, is clearly linked to the development of colon cancer and other issues. So I'm not against meat, but I'm against the amount we are consuming right now. That needs to be reduced. And in the same token, the processing of food is another risk factor for cardiovascular diseases and also development of cancers. And every food is somewhat processed. So if you take some strawberries and wash them, that's also kind of a processing. But there's different grades of processing, and whatever is highly processed with conservative and preservatives is bad for us. So we should really eat more like our grandparents did in rural environments, meaning less meat, more fresh vegetables, more fruit, less calories in general, and of course less salt and less fat and carbs.
Yeah, you know, you're a doctor, you have international experience. I was born and raised in the United States, so I have a home in Germany, and my wife is German, my daughter were born there, and I noticed that the grocery stores there.
Continue in German?
Huh? No,
continue in German now for your audience.
Yeah, no, because you know what? My understanding, my wife explains to me, is that in Germany, all the products that we buy for our daughter or she's a toddler, they're organic. And she said to me that it's by law, you're not permitted to have chemicals for any foods for kids. Whereas here in the United States, I feel like you really have to go the extra mile to get the sort of just the baseline quality of food in regards to your health. Whereas in Germany, it's regulated, it appears, at the retailer level and even at the restaurant level. I'm not talking about like a fancy restaurant, just a basic diner in Germany, a basic grocery store in Germany, not even high end. They appear to have less sugar, less chemicals. Whereas here in the United States, I live in both countries. It's free for all. They could put as much chemicals as they want. Now, what do you think as a doctor? I mean, you have international experience. What is that? Do you think that comparison is accurate?
I think so. I completely agree with you. I think here, I mean, and I'm not an enemy of the food industry, but I mean, it's all for consummation and profit, of course. So I think in other countries there's more regulations with regard to avoiding harmful substances for children, like you said in Germany. In other countries, like in the Netherlands, for example, there is iodine in every salt and in the water and in the bread, which we don't have. That's why they have such a low number of thyroid problems or thyroid diseases. There's a lot of things which basically, from an administrative governmental point of view, could be changed or done, but it's not done. So in America, it is more a personal choice. You can have it all, you know, you can have the cheap stuff and the high end, very organic. Organic does not always mean really healthy. I mean, it means something, but I mean, here it is basically the attitude is it's your choice. You can pick whatever you want. In my opinion, I always say, well, if you buy peanuts, you get peanuts, you know. So you might have to spend a little more money if you want the higher end, more cleaner foods, which have not that much preservatives, in particular for children. But when think about my own kids, of course, I mean, especially when they were smaller, I mean, we try to buy the best ingredients what we could get, and I remember that even as for baby foods, we imported that in part from Denmark because the products were so much cleaner and better rated than anything we could buy here right now.
You've authored a bunch of books on sexual dysfunction. What would you say is the relationship between cardiovascular health and sexual wellness?
Yeah, that's right. So sexual dysfunction is a vascular disease. Years ago, 20 years ago, people thought, oh, that is only to do with the psychological issues or with the hormone levels. People have not enough testosterone. That's actually just a very small proportion of patients. More than 80% of cases of male erectile dysfunction is a pure vascular issue. It is based on what we call endothelial dysfunction, which is an inability of the blood vessel cells of the inner layers of the blood vessels to react or to dilate or contract. And endothelial dysfunction is, like I said, is a disease, and that leads to erectile dysfunction. But at the same time, it also leads to stiffness of the blood vessels. It reduces elasticity, and it leads to the deposition of calcium plaques and cholesterol plaques in the arteries. So it's a two-sided thing, if you wish. On one hand, and erectile dysfunction is a vascular problem. On the other hand, erectile dysfunction is often like a first sign of an underlying vascular problem. So if there's a problem with the blood vessels in the genitals, there could be a problem with the blood vessels in the heart and in the brain. So if I see a patient with erectile dysfunction, which I see almost every day, then of course my first thought is, well, there might be more than just that one problem. And those patients do require a cardiac workup and a vascular workup because the heart could be affected as well.
So for example, like if a person doesn't have you as a doctor, and they want to understand their cardiovascular health much better, what are the specific tests that they should request or be aware of?
Well, it depends on the symptom, and it depends also a little bit on the way medicine is provided. So we are still practicing what is called reactive medicine, meaning someone comes to me because that person has symptoms, chest pain, erectile dysfunction, you name it. So we react as physicians to that symptom or that problem, and then do some diagnostic steps and then come up with a diagnosis and a treatment. What we should do instead is we should not react, but we should switch that whole paradigm of reactive medicine to two others. One is preventive medicine and the other one is regenerative medicine, using stem cells, for example. So we should not come into the picture at the time when there's damage already, which causes symptoms, but we should come into the picture earlier as educators and providers to prevent the problem in the first place. And then once the problem is there, just to react to it by prescribing pills is helpful, but is not solving the problem. Instead, it would be much better to repair the problem. And that's where we close the loop, basically going back to stem cells, because stem cell therapy, not yet, but in the near future, is part of regeneration and repair.
What, so like, for example, if you get your ApoB level tested for your, cardiovascular health, what would you say is an ideal number to have for optimal health?
It really depends on the lab. So, sorry, I didn't really answer your question before you asked what test should someone. So it really depends on the labs, but I wouldn't even go to an ApoB. The first thing is, of course, if you want like an assessment of your overall biologic health, there's different ways to do that. And you didn't ask about that, but there's those tests you can buy for $500. It gives you your biologic age. In my opinion, that's complete. There's no scientific merits to that at all. There is no single test, not even one, which gives you your biologic age. There's different ways to measure the biologic age of, let's say, your blood vessels or your chromosomes or your cellular metabolism or others way. But there's no one single test which gives you, oh, you are 50 years old, but you look 75. That is just more a marketing thing than anything scientific. But what you should do, of course, you should have always at least once a year complete physical by your doctor. And you want to assess those factors which we call risk factors that contribute to aging and to especially cardiovascular aging. Meaning you want to check your blood pressures, not like some people do 50 times a day. There's no sense to do that, but once or twice a day if it's not completely normal. You should check your sugar levels, because diabetes, even pre-diabetes, nowadays is a condition which is considered a risk factor for heart disease, strokes, kidney failure, and death. And you should your baseline lipid levels. You don't need the lipoprotein subfractions. You just need a simple lipid panel where you measure your total cholesterol, your good cholesterol, the HDL, your bad cholesterol, the LDL, and your triglycerides. And if they are completely at goal, then you are fine. And in most of us, they are not at goal, and then you should do something. The problem we are facing as physicians is that, for example, people have elevated blood pressures. They come to the office with blood pressure of 150 or 190. That's not sky high, but it's elevated. And then the doctor might prescribe a medication to lower the blood pressure. And most patients say, well, it doesn't hurt. Why would I take medication? Well, why would you take medication? Because high blood pressure, elevated blood pressure, is what we call the silent killer. So if you are not, if the blood pressure is not controlled, you might not feel it. It doesn't hurt you now, but in 5 years, your kidneys might be down the road, or you have a heart attack or a stroke. And we see people now, I see people every day in their 40s ending up on dialysis because they have since 15 years high blood pressure and didn't take it serious enough. And now it's way too late in the game.
When you say high blood pressure, when you say 15 years high blood pressure, what you like 150, 90? Is that what you would?
No, everything above 130 over 80 is considered elevated blood pressure.
Over 130, over 80.
Yeah. So if I measure 10 people in my office now, blood pressures, I guarantee you half of them have higher levels than that.
So what happens if someone has? So what happens if someone has 135 and 80?
Well, one measurement doesn't make a diagnosis. We do repeated measurements under resting conditions, and at different times of the day. So I don't overdo it with prescribing everybody medication. But if someone has like 135/90, for example, which I see all the time, then I tell them, your blood pressure is a little elevated. And the first thing is you have to reduce your salt intake, meaning change your dietary habit. And second, exercise 5 times a week, 30 minutes minimum per week of moderate intensity exercise. Check your blood pressure twice a day, once in the morning, once in the afternoon, usually on the left arm, at home, after sitting down for 10 or 15 minutes, meaning under resting conditions, and write that down and see me in 2 months and let me look at that. So exercise and diet can help quite a bit, and not everybody with borderline elevated blood pressures needs medication. I've seen a lot of patients who, for example, were mildly or more than mildly overweight, and they lost the weight and they didn't need blood pressure medications afterwards.
For athletes, like I love boxing, and I know people talk about the V02 Max Test, and the relationship and how it correlates with longevity. What do you think about that as an indicator of your longevity, the V02 Max?
Well, I mean, the V02 Max in the clinical setting is not a standard test, which is done if someone comes in and wants their heart checked. The V02 Max is standard only in the preparation for someone who is considered for a heart transplant. And the reason is basically very simple, because nobody pays for it. So the insurances only pay for a cardiopulmonary exercise test, which measures the VO2 max, if there is a medical indication, which is like I said, a transplant workup. Other than that, insurance companies don't pay for it. They might pay for a regular exercise test, like on a treadmill, or sometimes we do chemical exercise tests or stress echoes, but that's a different story. They don't measure VO2 max. That's just,
would you say?
Mm-hmm.
I'm going. Tentatively plan is to go next month to Prenova. I got an appointment for my mother, my wife, myself, and I spoke to the lady at Prenova. I'm sure you're familiar. They do it's an MRI, and it's like 500 illnesses, cancers, and I said to her, I said, how come everyone doesn't do this? When we have this artificial intelligence, we have this technology, tens of thousands of images. And she basically said that the insurance companies don't pay for it. And it's interesting because now here you are saying the same thing. Like, you didn't say, oh, the VO2 max is worthless. You're saying it's because people have to pay for it. So it's basically just a financial barrier. But other than that, like someone like me, if I just want to get, I'm 43, I want optimal health. I want to live as long as possible, high quality as possible. People like that had children, and do you think a VO2 max test is something maybe I should do once every 6 months, once every year, and then I could measure it and prove it? Or do you think what would you advise someone like me that wants to take a preventative approach?
I think it's
preventative.
It's unnecessary to do it.
Really?
Yeah. If you're a healthy person, it's completely unnecessary to do it. If you have it done, or if you want to do it one time to see your cardiac capacity, that's fine. But there are simpler ways to check that. You can do a simple exercise stress test, for example, on a treadmill. It's an academic parameter, meaning we use that in certain studies, for example, if we want to know if the heart failure of a patient with cardiac insufficiency, for example, is bad enough to warrant more aggressive surgical therapies. But other than that, if you would ask my opinion, should you do that twice a year or every year? No. I mean, there is no clinical consequence of doing so, unless you are sick. But coming back to, you mentioned the company Prenovo, I can tell you, I did the same thing,
Wow.
and it costs quite a lot of money. I mean, I think $2,000. Yeah. And it takes, I think, 45 minutes or an hour. You're laying there. You can watch some Netflix movies during that time. And one of the reasons for me to do it was because I've never done anything. And if I have an hour where I don't have to do anything, that's very rare. So I kind of enjoyed it. When you do that, you get a report after a week or so, which is this big, and then you find 1,000 things which are wrong with you. But it's a good thing. I'm completely for it. I'm a big promoter. I have sent several of my patients to do exactly the same. And just a few days ago, I saw a young lady who I sent for that, just for precaution, because, I mean, like I said, I was talking before about preventive medicine. So I think it's a good idea to do like an overall whole body scan. In that particular case, a relatively young lady in her late 40s had it, and she, as a surprise, completely unexpected, had several lesions in her bones, in her legs, which looked very, very suspicious for cancer. Again, this lady had no symptoms, had no complaints, but this is something, I mean, I was surprised, and so were the radiologist who read that and recommended, of course, further diagnostic testing. Actually, today, that lady is at Cedars-Sinai in Los Angeles and is getting a biopsy of her bones to rule out or rule in whatever we found in that pre-nuvo scan. It might be cancer, it might be something harmless, but without having that done, that could have ended badly, because if it is cancer and undetected, because many cancers don't make symptoms until it's too late in the game, then it would be a different story. So in this regard, if it would be if someone asked me, I would say absolutely have that pre-nuvo or others, a total MRI done of the body, just to check for everything, because you never know. There might be things in your body growing which you're not aware of. And the biggest thing we are concerned about is, of course, the development of any tumors anywhere in the body. So I would do that. And if you ask me how often, it depends really on the finding. If it's completely normal, then maybe again in 2-3 years. If there's some major abnormalities, then maybe earlier. But again, it is expensive. No insurance company pays for preventive medicine at this point for testing like that, at least. And $1,000, $2,000, I think, is what it did cost. Is a lot of money for a lot of people.
How important do you think? I got my C-reactive protein cardiac tested, and it came out 0.19. Would you consider that optimal? Would you consider that awful, or what would you say would be?
No, it's not awful. I mean, CRP is the C-reactive protein is a complete, what we call non-specific inflammatory marker. So if you have a tooth infection, for example, then your CRP is elevated. If you have diverticulitis in your colon, then your CRP is elevated. If you have an acute bronchitis, then your CRP is elevated. So
would you consider?
It only tells you that you might have an inflammatory process in your body ongoing. And if it's a chronic elevation, then as I said earlier, chronic inflammation is a risk factor for cardiovascular diseases. So that's why people often measure that high sensitive CRP as an indicator, more or less, of any cardiovascular issues. But it's non-specific. If it's high, well, then repeat it maybe in a month or so. And if it remains high, then have more testing done.
Can you, since it is such a, this inflammation marker, helps you, predict the risk of your heart disease, I guess here. So can you get it to 0?
Well, I don't think there is such a level as 0.
Okay. Yeah. So, but if it's less than 1, would you consider that optimal?
Well, I'm not sure if there should be a range of optimal or good or better or worse. Again, it depends on the whole situation, of course. I just was rounding on a patient an hour ago at a CRP of 150. But this is someone who has open wounds on his legs, which are infected now. So again, any infection is a risk and any inflammation is a risk. It's too unspecific to really make something out of it. In the frame of a complete blood workout, for example, workup, including lipid panel, it's not a bad idea to look at the high sensitive CRP as a non-specific marker, but it doesn't give you a diagnosis.
So I have three biomarkers that I would like to ask you here, just to see what you would say would be the optimal health number for longevity. One is LDL cholesterol. What would you say is the optimal number for that, for one of your patients, for example?
Well, again,
Dr. Schwarz, Dr. Schwarz, this is a patient that does not want to be reactive. This is a patient that is saying, I want to prevent and avoid ever having to come to you with a sickness. So they say, my LDL cholesterol is, NIH is, what number would you say you're doing good? Or what number is bad?
I mean, there's clear guidelines from the American Heart Association published years ago and revised a few years later. So if you don't have diabetes, heart disease, peripheral vascular disease, a level between 70 and 100 is optimal. And that was basically something which we always geared for. So ideally less than 100. Keep in mind that 15 years ago, that level was 130. Then it went to 100. If you have any of the above conditions, for example, diabetes, hypertension, or coronary artery disease, then a couple of years ago, the goal was to get the LDL level, the bad cholesterol, to less than 70. But even that has changed over the last couple of years. Now some people recommend less than 50. So that is now the gold standard now, to go less than 50. So keep in mind that not everybody believes that that is really the way we should go, because if your cholesterol is way too low, and I can't give you a number for that, but we don't want the cholesterol too low in general. I mean, we need some cholesterol. You know, people with too low cholesterol have hardly any production of sexual hormones, for example. So,
but if it's 130, you mentioned 130. If it's 130,
130 for a healthy person is way too high.
Wow,
way too high. Yeah. And if you are not obese, and if you eat right and exercise, 130 would require most likely then lipid lowering medications. It's not the first step. Of course, the first step is exercise and diet. But I have a lot of people, middle age and young patients, and they do everything. They do the exercise and they do the healthy diet, and the LDL is 130, 140 is way too high. So sooner or later, they need to be put on lipid lowering medications in order to reduce their 10-year cardiovascular risk. Well, the first thing, if the lipids are not at goal, is not medication. The first thing always is diet and exercise. So low carb, low fat diet and cardiovascular exercise to burn calories. And usually I recommend that for maybe 3-4 months. And if they do that in the right way, then repeat the lipid panel, look at the blood levels again. And many people might be at goal, then maybe below 70. If that's not the case, then either they are not on the right diet or don't do the right exercise, or they then might require lipid lowering medication.
Got it. All right. And then how about for ApoB? What would you consider a good range for ApoB?
Again, I don't measure that as a routine test. It depends purely on the lab because different labs have different ranges, which is considered abnormal. So I only would send someone for an ApoB subclassification measurement if the LDL cannot really be controlled with diet, medication, and exercise alone, or if I believe that there's any familial hyperlipidemia, which needs to be further further distinguished. But I mean, it's not anything which is in clinical routine even measured. I mean, that's more an academic issue than a clinical issue.
Got it. All right. And then, yeah, I mean, so how about vitamin D? How would you say vitamin D plays a role with heart health, cardiovascular health?
A lot. I mean, there's tons of studies published, and my group has published on that a couple of years ago. Also, there is a clear link between vitamin D deficiency and the occurrence of cardiovascular events. So there's no doubt that vitamin D deficiency is a bad thing for the heart and the blood vessels. The issue is that most of us are vitamin D deficient, and I mean, I'm not taking many supplements, but I can assure you that I take vitamin D every day. So we did a study a couple of years ago, and 2-3 years ago, we published a paper to look which supplements have proven scientific evidence from clinical studies, smaller or larger ones, with regard to cardiovascular health. And it's not what you might think, like the fish oils or the CoQ10 or those. I mean, there are some subclasses. CoQ10 in combination with statins, for example, are beneficial. But the ones where we found most evidence for substitution in order to overcome cardiovascular risks is 4. Vitamin D is one. Nitric oxide is the other big one. Resveratrol, which is in red wine, and turmeric or curcumin. So those 4 supplements have significant clinical data published to support that the substitution might be beneficial in reducing cardiovascular health. There might be additional ones, but they don't have scientific proof. So, and if someone sells you a product and says, "Oh, this is clinically tested," that doesn't mean anything. Everybody can put a pill in a bottle and tell them, "Oh, it's clinically tested, it's good for your health." It has no merits whatsoever. There's no FDA looking at that. Nobody can prove what is in. For example, that whole multivitamin thing, I mean, is absolutely overrated, in my opinion. There never ever was any study published which showed any benefits of taking a multivitamin. In contrast, if you have documented deficiencies of certain vitamins, like vitamin D, for example, then absolutely that should be taken and supplemented in order to avoid damages. There's very, very few products available which have really undergone the basic testing, the clinical testing. Nitric oxide is one of those, and I was involved in certain clinical trials using that. And very few of those cardiovascular supplements. I know for sure there's one coming out, I think in the couple of months, where we also were participating in some clinical studies to show that there's no harm and potential benefit. But again, the general, I see a lot of patients coming into my office and they take 50, 60 different supplements every day. I mean, there's no proven benefits. It might not harm, but is it necessary? No, I think it's necessary really to react to deficiencies. And there's very few products who really have that contents which I mentioned of those supplements, which are really have proven benefits for the cardiovascular system.
What we were talking about the LDL cholesterol, as the biomarker. What about lipoprotein? That's a sort of LDL, right?
Well, lipoprotein is basically the subfraction of the cholesterol. Yeah, LDL is density lipoprotein, HDL is a high density lipoprotein. Yeah, that's
so could you well then could you have like a healthy lipoprotein but a bad LDL as a biomarker, or are they not?
LDL is a lipoprotein, so is HDL. HDL is a good one, LDL is a bad one.
Okay. So before we were talking about the LDL being at 130, that's too high. So, but what if a patient said to you they have an excellent lipoprotein? Could that make sense, or is it usually both biomarkers are bad?
I don't know what that means. That doesn't mean anything. I mean, which lipoprotein?
Hey.
That, again, that has no clinical relevance if the LDL lipoprotein is elevated.
Got it.
So the idea that the HDL, the good cholesterol, more or less, completely negates the bad cholesterol. So in other words, if the good cholesterol is high, but the bad cholesterol is high, then, oh yeah, that's a good thing. I don't need to do anything with the bad cholesterol. That is really obsolete. I mean, we don't believe in that anymore. There might be some neutralizing factors, but even if the good cholesterol is high, but the bad cholesterol is high, I want the bad cholesterol down in order to reduce the risks.
So, but do you see patients that have the 130 for the LDL cholesterol NIH, but then they have a healthy APO protein A?
Yeah,
do you see that?
Yeah, of course. I still want the LDL down.
The LDL down. Got it. And because there's some people that are very athletic that they look very healthy, but they may have a higher LDL.
Of course, absolutely. And yeah, so we still consider an elevation of LDL as a cardiovascular risk factor. So there's a lot of people are very athletic and they drop dead tomorrow of a heart attack, So, and then everybody say, oh, how can he was so athletic and ate so healthy? Well, because there might be some genetic factors which led to hypolipoproteinemia, meaning LDL elevations, and that's considered a risk factor. And I have seen patients at young ages in their 30s, 40s, without any other risk factor, just with elevated LDLs, having coronary artery disease at a premature age with 90% blockages and needed stents.
Do you think coffee makes it worse?
Coffee doesn't make it worse, no.
Oh, coffee doesn't. Okay. So if they drank 1 or 2 coffees a day, that wouldn't give them a higher situation.
No. What makes it worse in athletes is testosterone.
Yeah.
Testosterone substitution, and I'm not against it in general if indicated, but testosterone is a good thing for certain things, but it lowers the good cholesterol. So that needs to be watched. And I see a lot of athletes on testosterone, especially bodybuilders, take a lot of testosterone, but you have to keep in mind, you have to keep an eye on the red blood cells, you have to keep an eye on the prostate specific antigen, you have to keep an eye on the lipid panel, meaning the cholesterol levels, and on the thickness of the heart muscles, because all this can be affected by testosterone.
All right. And then I got, it's my last question here. Thank you for your time. What you're doing with stem cell research, regenerative medicine, everything you're seeing with international experience, you're at the forefront of what's going on. Do you think a lot of the cancers that people are getting today, in 5, 10 years, people will be able to have much higher survival rate with
I,
what's
I have
happening?
I have no doubt about that. I mean, I'm not in the cancer world. I'm not researching cancer. That's forest away from me. But there's I don't want to say the name, but someone well known, not far from my institute here, who works on vaccines for cancers, for example, very successfully. And there's nothing ready yet for broader use, but I mean, there's lots of studies ongoing to treat cancers nowadays differently than the standard therapies with chemotherapy and radiation. But the number one goal is, of course, to prevent them or try to prevent them. And so far, unfortunately, we haven't found good ways to do that. I mean, in certain cancers go downhill in numbers because, for example, people smoke less. But others, like colon cancer, is absolutely on the rise among young men and women, especially in this country, and in part for sure because of the typical American diet we all unfortunately consume.
Basically, the high red meat consumption.
Part of it, yeah. Processed food, high red meat, too fatty, too carb loaded, and it's. I mean, we have to go back to the basics and roots of our grandparents.
Yeah. Well, thank you very much for your time. This was amazing.